since we were on time, right? Let's begin today's event entitled Innovative Training of Birth Attendants. My name is Sandeep Bathala. I'm a Senior Program Associate with the Maternal Health Initiative here at the Woodrow Wilson Center. Today's event is brought to you as part of our Advancing Dialogue on Maternal Health series, which looks to identify critical and neglected maternal health issues and identify strategies for advancing the maternal health agenda. This series is generously supported by the United Nations Population Fund, or UNFPA, and the Maternal Health Task Force. As many of you know, the Wilson Center aims to bring the worlds of policy, practice, and academia together so that we can better inform one another. But did you know that we were recently voted the top think tank to watch in the U.S. and among the top 10 in the world? So thank you for your support of that and ensuring that we do have that ranking. Speaking of things to watch, I did want to point out that today's event is being webcasted live. So what that means for you folks here in the audience is that when we come to the discussion, I'd ask that you use a mic, and my colleagues will be around with them. And please identify yourself and affiliation, especially so those tuning in will know. I also wanted to mention the Twitter handles for today's event. We are using hashtag MHDialogue as well as hashtag Day 456 or day 456, and what that actually signifies is that we're 456 days away from the MDGs coming to conclusion. So there's some dialogue today, and given our topics and given the MDGs that in particular focus on maternal and child health, we are using that tag today. If you do need access to Wi-Fi, we have the passcodes on the wall. I do want to point out that we do change the passcode every 2 months, so if you've been here before, you might need to reload the username if you're having any problems getting online. I wanted to direct your attention now actually to our stellar panel today. We're going to first hear from, and I'll introduce them along the way. More detailed bios are available outside. So since they're as esteemed as they are and their bios are as long as they are, I will actually just limit my comments to introductions right before they start. So we'll first hear from Geeta Lal, who's the Senior Advisor, Strategic Partnerships in the Sexual and Reproductive Health Branch of UNFPA. So we'll hear from her first. Thank you.
A very good afternoon to all of you. It's an honor and privilege to be here and presenting at the Woodrow Wilson Center. And I feel deeply humbled to be in this panel with fellow panelists and gurus of innovation like Dr. Harshad Sanghvi and Dr. George Little. I'll be talking today about some of the innovation work that UNFPA has been doing with partners like JPIGO, Intel, and the World Health Organization in scaling up midwifery education and life-saving skills through innovative technology-driven approaches such as e-learning. So what are some of the key challenges? We know that even now, millions of newborns and several 100,000 women are dying needlessly. And what makes it so sad is they're dying from preventable causes of maternal and newborn deaths. I mean, those causes could have been easily prevented. And what are the reasons behind these unnecessary and needless mortality that we see every day? One, of course, that is gaining now increasing prominence is the acute shortage of trained health workers and midwives in particular, especially if you're talking about maternal and newborn health and deaths. The second key challenge is that we lack the right institutions, the facilities, even where they exist, they are not properly equipped, or the doctors are not there, the trainers are not there, and clinical skills training is particularly lacking when it goes to training of healthcare workers and midwives. The quality of training is extremely poor. That's also we are finding again and again and again. And last but not least, we find that retention, deployment, and distribution issues are there. So even if we are training, we don't have the numbers, so it's an issue of numbers. The second is the issue of quality of care. Third is the issue of equity, that services where they're needed most are just not there. And fourth is the key issue of access. that how do you access those services. So this is in a nutshell some of the key challenges that we face. So the point I'm trying to make is that if we are to go to scale, if we are to really make a dent, everything is not all that bad. When I was talking about challenges, we know that maternal mortality has been steadily decreasing, that newborn mortality has been decreasing, that under 5 mortality has been decreasing. But is it at a rate that is fast enough? Is it adequate? Or does something more need to be done? How do we take these things to scale? So really, innovative solutions are needed. And the fact is that by end of 2014, and here I'm going to cite some latest figures from the Broadband Commission report, which just came out recently, that there are likely to be 2.9 billion users of the internet, and these people will be online, and that corresponds to roughly 40% of the total world's population. The second big figure is that there would be 6.9 billion mobile subscriptions. So the world population is about 7 billion people, 7 billion plus. And out of that, about 6.9 billion mobile subscriptions. Of course, we are looking at double mobile subscriptions, etc. And 3/4 of these, about 5 billion, are in the developing world. And again, as you see, this is the International Telecommunications Union statistic from 2014. There's rapidly increasing broadband access. And today, the falling cost of netbooks and laptops. When I came to the US, I love citing this example. The first laptop that I bought cost me $2,000. This is in 1996. That's what I paid. And today, I think by the end of this year, it is estimated, and I was speaking to Intel last night, that it's likely to come down to just about $150 to $100 mark would be the cost of a tablet. So really, I mean, this is the argument that is often thrown to us, that you are promoting education and training of healthcare workers using something as costly as a netbook or a laptop. But what I want to say is that is a fallacy, because the cost of one laptop today could be less than the cost of midwifery books that we supply to a student for 3 years. So we have certainly evolved. And again, technology can help. Again, that's the point that I've been trying to make, and we should use that. The figures out there are not a myth, and we need to use that power of technology that is really out there to reach out to people. I mean, even where people don't have food to eat or an adequate roof over their heads, they still have a mobile phone. So the mobile phone penetration, the broadband penetration, so these are no longer myths, and where the world is headed, I think I'd be safe to predict that the next generation of children that goes to school will not be carrying a big backpack full of books, a sack of books. They'll be carrying a small laptop or a netbook or a tablet, which will have all their course materials in it. So what did UNFPA do? Of course, we do a lot of needs assessments and studies. We try to find out what the situation is out there. But we've also been thinking of solutions together with great partners all across the world. And in 2012, we signed a memorandum of understanding with the technology giant Intel, because Intel at that time had also pledged that they would try and reach 1 million health workers by the end of 2015. And they were also looking out for partners, and we were also looking out for, or getting on the path to finding out other solutions to address the core challenges. And this partnership was then expanded to include JPIGO and WHO, the World Health Organization. So what have we done? And I'm going to show you a small film after this slide, which talks for itself. We have developed high-quality, interactive, multimedia e-learning modules on all life-saving skills. So one is training of healthcare workers and midwives. But when we're talking about mortality and morbidity, then what would save the lives out there? It would be these life-saving functions, critical life-saving functions like pre-eclampsia, eclampsia, postpartum hemorrhage, sepsis, etc., that would really go and make a dent on saving lives. So high-quality multimedia e-learning modules have been developed. What has Intel provided us? They have provided us at no charge a platform that they have developed called the School Platform, SKOOL, School Platform. And this provides a solution to offline access to training courses. So we are using that platform on which we have built our courses. So that also provides offline capability, and we can translate these modules into any language. The modules have built-in assessments. So they're quizzes, so it's not just people taking courses. You can also track at the back end what is the result of the training that we are providing. They're customizable. They can be localized into any language, any local cultural context. They have been endorsed by the International Confederation of Midwives, International Council of Nurses, and FIGO. So we also got them tested, by these three big professional bodies, and they have looked at the content and provided comments, and it has been vetted by them. And the second part is that when we are looking at a program that aims at building health worker capacities using low-cost netbooks and laptops, then we are looking at a multi-user kind of a program, in the sense that the same laptop, it's not just for training that the health worker can use. That same, once the health worker is competent in computer skills, you can also use it for data tracking and recording. So the advantages are, one, in training. So it will improve the quality of care, it will improve coverage and access, it will improve accountability, and then licensing and relicensing, which is almost non-existent in the developing world. So you developed, short modules which midwives and health workers can take, upgrade their skills, and then apply for licensing and relicensing. The second thing is data tracking, as I just mentioned, that if the health workers are trained in the use of these netbooks and laptops, and they have one in their possession, they can also track patient data. They can track patient visits, ANC, PNC, postnatal care, delivery, all these visits and patient records. So it's a multi-user kind of a framework that we are looking at, and multiple benefits that would arrive from this kind of a model. I'd like to show you a brief film that we made on these modules, which will speak for what has happened since we launched this program. So I'm going to stop right there, and we can discuss further in the question and answer session. Thank you so much.
Thank you, Geeta. You referenced the question and answer discussion, which I'm really looking forward to. I'm really looking forward to hearing a little bit more about this partnership, and how you said that Intel pledged to reach 1 million health workers. And I'm wondering, did you pair up with them before or after their commitment, and how that came to be? But we can wait for the discussion. I thought you brought up some really good points too, and that's around the data tracking and using these instruments in multiple ways, which I think is great, and just ensuring that can be used offline, because we know that can prove challenging if we were to depend only on online accessibility. But you talked a bit about the partnership with JPIGO, and we're very fortunate today to have the Vice President of Innovations and the Medical Director of JPIGO with us, Dr. Harshid Sanghvi. We're really, really honored to have you join us. Thank you.
Well, thank you very much, Sandeep, and it's a delight to be here at Woodrow Wilson Center. What I'm going to try and do is not only speak about training, but how we maximize our investment in training, how we're going to do that, because I think at the end of the day, we want impact of our training. I think from my perspective, we have much to be happy about in terms of the achievements that we have done in the last 10, 15 years. But our job is not done, and clearly there are many, many countries that are still not on track to achieve MDGs 4 and 5. But we are about to set some new targets, and I think we are about to set some unprecedented targets that we have in the past not even been able to reach. But we are about to set those targets, and I think it's a good thing that we do set these kinds of targets, because it's a shame that a woman should die during childbirth. No woman should die during childbirth. No child should die in childbirth as much as we can. So our targets are going to be about ending preventable maternal and child deaths. From my perspective, to be able to do that and set unprecedented targets, we also need unprecedented commitments. We need new partnerships, and I really want to focus in my talk about these creative partnerships. In some ways, I often think about, we often get together in meetings of like minds, but what it's going to take is bring people of unlike minds to focus on a problem. And I think we need to think about that. Clearly, innovation is important, but it's not just technology innovation that we need. It is systems innovation. It is program innovation that I think is needed as well. And lastly, I think we need to talk about scale. And really, we should not be making any excuses about scale. My definition of scale is achieving universal coverage at scale. My definition of scale is getting quality at scale. And my definition of scale is about getting impact at scale. I think anybody who has got a lesser definition is not going to get us to those unprecedented targets. So let me go into some of the things that I want to say about this. Now, I think many of you have seen this slide. It's been out there often. I think we have a significant level of scientific understanding already in terms of the interventions that we want to do. We know what things we have to do, but we don't necessarily do that in patient care. So there's this implementation gap. And I think Margaret Chan said it best, that our systems just do not seem to have the ability to implement what we already know sufficiently. So I think for me, there are two components of how we are going to bridge this implementation gap. One is certainly by training, but the other one that I want to focus on a little bit more is clinical governance, ensuring that people put into practice the things they have been trained for. So let me just take this example out of India. This is a fairly new registry, which was just started by a professional organization in India, and they just got many hospitals to submit by SMS some key information about eclampsia. And over a period of time, they collected information about preeclampsia from almost 100,000 pregnancies. That's larger amount of information than they've ever had in terms of any information about preeclampsia. But more important, they were able to identify some gaps in implementation. So for example, only 44% of the cases of eclampsia received magnesium sulfate, which is sort of the drug of choice, which is cheap, inexpensive, and really effective. Many people were using other drugs which are actually more expensive, less effective, and actually more dangerous for the baby and the mother. So here we go, some information that we've known actually since the turn of the last century, right? So this is information we know from almost 100 years, and yet this is not necessarily reaching the level of implementation that is out there. The second part of the response from these 100,000 was that it took 32% of people more than 4 hours to start this therapy. Now, eclampsia is a very serious condition. If you don't get your treatment in very quickly within the first hour or so after the convulsions occur, then you get mortality. The sooner you get this therapy in, the better it is. 4 hours is just not a good standard. Doing it in half an hour from the time of convulsion is probably a better standard. So a majority of patients in this well-served nation are not getting the treatment in a timely manner, which, as a result of which, people are getting recurrent convulsions even while they're in the facility, right? So all of these things lead to now preeclampsia becoming one of the leading causes. Now, none of these interventions, for example, injection of magnesium sulfate, really require a training approach. If you think about it, they require knowledge and implementation. There's no training required to do that. Most of them just require that knowledge. Here's data from 6 other countries from MCHIP, which was a USAID supported flagship program, from 6 countries, again related to preeclampsia. And you see the statistics are fairly poor. To be able to detect preeclampsia, you've got to do both the blood pressure and the protein test. Very few women were having their protein tests done. Very few women had repeated blood pressure taken during the course of labor. Very few people had even the questions asked about signs and symptoms of preeclampsia. So here are some things fairly simple to do, but we've not been able to do them in our healthcare system. These are very large surveys that were done. So from my perspective, this needs a slightly different approach from training. And this is an example of an approach that we used in Nepal. So we basically gave a small sum of money to Nepal professional associations to go out and do a one-day visit to hospitals. In that one day, they updated everybody on the standards of care for preeclampsia and eclampsia management. They went ahead and provided any additional, filled any training gaps they already had in terms of their knowledge, in terms of their capacity, and in terms of their skills. And then they went ahead and did an assessment of the institution in terms of where the gaps were in terms of their practice. And they decided on some actions to take. They left them there and used cell phones to call them every 2-3 months to figure out what changes they had made. And we are measuring now how close they were to achieving universal standard of care. So a training approach and a clinical governance and a performance improvement approach all rolled in one. And as you can see from the data, there was a fairly rapid increase in the proportion of hospitals that were now practicing to standard. All right? So I think for me, using this combined approach, a blended approach of training as well as governance, actually has a better chance of making impact than just a training approach. Now, we have a major challenge. This slide shows our major challenge. The number of midwives that are available. So it's actually very interesting. There are a few countries which have more midwives than the WHO, the World Health Organization, prescribes. So the World Health Organization thinks that we ought to have 6 midwives for every 1,000 births. In some countries, we actually have more midwives. That doesn't mean that we are getting better care. So it's not only about the numbers of midwives, it's about the skills of our frontline workers, our healthcare providers. And the biggest challenge from my perspective is actually that either they are not skilled or they're not practicing the skills that they know how to do. So how do we address that particular gap? So for me, one of the biggest investments that we ought to do is to fix our midwifery schools and our nursing schools and our schools for frontline health workers. Jhpiego was very fortunate to be in Afghanistan for many, many years since we were first able to go out there. And at that time, the midwifery schools had been wiped out completely. And well-meaning donors came in, and very soon we had 23 different curricula for nursing education and midwifery education. And after some time, we had to bring everybody together to focus on one way of doing things. I think we succeeded in Afghanistan to create a better midwifery workforce. And I think Afghanistan can be really proud of the midwives they are producing now from their midwifery schools, because the training in that midwifery schools was focused on what nurses needed to do. Their practicum was not in big city urban hospitals. Their practicum was in home births, including births at facilities, because that's how it was going to be practiced. We knew right from the beginning that many of the student midwives, 19-year-olds, 20-year-olds, already had children. So we had to make arrangements in every midwifery school to make sure that there was a nursery and a nanny to look after those children. We recognized that the access to knowledge was through internet. So we had to teach them English as well as computer studies as part of midwifery education. And I think as a package, all of these things were not just about training a midwife. It was about empowering her with knowledge and abilities. And here's an example of a midwife who I met in Afghanistan. She's 19 years old. She heard about a client, a patient at home who had apparently was bleeding. So she went to her house, talked to the husband and said, "Look, I'm a midwife. I can help your wife." And the man said, No. She is bleeding and I don't think you can help her. You don't have any tools. What can you do? So she went away and came back again after an hour, pleaded with the guy to allow her to take care of the woman. He refused again, and 2 or 3 hours later she came back. And this time he allowed her in. And what the woman was having was a retained placenta, something fairly dangerous. And she was bleeding, literally bleeding to death. Now she went ahead and did a manual removal of placenta right there and then. Now this is a procedure that midwives and physicians are actually afraid to do, even in the best of settings. But she went ahead and did it because she was empowered enough to stand up to this guy And she was also empowered by the knowledge and the competency and the capability and the proficiency that she had during the course of her training. To me, that's important. She cannot do these things unless she was super confident. Our midwifery schools must end up with proficient and capable midwives. That's what our goals are to be. We don't want a long internship after that to become proficient. They need to become proficient while they're in midwifery school. To me, this girl, this very young girl, actually really shows that it's possible. And she's saving lots of lives out there, and her friends are saving lots of lives. So we have a challenge, we have a similar challenge in India. This is Bihar. Again, in Bihar, we have the need to skill up vast numbers of midwives that are needed for India's massive population. And we use the quality improvement approach to improve the capacity of the midwifery schools to train their midwives. And these are the before and after, or before and middle scores in terms of their standards. But the Indian government is desperately trying to get hundreds of thousands of midwives skilled up. And I don't think our traditional ways are actually going to achieve it. So we are testing a new method, a virtual classroom method. So Geeta talked about those modules that we have created. We have advanced those modules not only to impart knowledge and decision making, but also skills type of training. So here's what we do. We have 2 sites in Bihar where instructors will present the training. So they are the best trainers in that whole of state. We bring them together to these sites and they will do the training virtually to almost 12 schools, students in 12 schools. These training programs are very interactive. So there's knowledge being imparted, there's decision-making case studies that are run, and then there are demonstrations that are done, and then facilitators in the classroom facilitate return demonstrations. So nurses are practicing those skills. We've reached many schools. Now, why is this important for us? Well, I think it's important from 2 perspectives. First of all, every student in those 12 schools are getting a standardized education at the highest possible level. The second part of this is that the teachers in those classrooms are having time now not to spend on didactic training, but have more time to focus on clinical training, getting those clinical skills trained, because they don't have to worry about all of the classroom training that's being done centrally. It's efficient. And we've been asked now we've just finished evaluations of this, and we've been asked to scale this up to almost 500 A&M schools in India. The results are very good. At the end of each session, we do knowledge assessments. They're very, very promising, and students actually like this particular way of learning. So majority of them are in the green and yellow zone, right? Small number of people still find it's poor quality, but by and large, it's a better way to scale up this kind of training. Okay, let me move on to a couple of other thoughts. One of the things that we try to do is figure out how these health workers work as a team. Now, if you think about this, our classrooms are not the best places where everybody in a team might be, right? Physicians, nurses, anesthesia, pediatrics, and everybody. So we use clinical settings to do drills, in which we will have drills in which the entire member of the team learn how to respond to an emergency. These are simulations, but they are taught when there is downtime, when nothing is happening in the labor ward. We suddenly run a very quick drill. And each of these individuals has a particular role that they are expected to play. That starts reducing the emergency response time and the efficiency with which emergencies are trained. I think this works very well. People love it. And then they do them on their own. This is our program in Indonesia, the EMAS program supported by USAID. And what they're doing is making data visible to everybody. So there are standards in that particular institution, and we're working in almost about 60 or 70 70 plus medical institutions where every aspect of their work is monitored using electronic devices, and they collect this information and put it as a dashboard in the labor ward. So take a look at midwife-patient ratio. So they've decided that they would like to have one midwife for every 2 patients. If this ratio goes to more than 3, that's bad, and that's recorded. So they measure every week what proportion of time there was this not so good a ratio. And that sort of drives some change at the end of the month. And I think using this information and comparing this information between institutions, they're able to start observing changes that they are making. So it's very empowering for people to see, health workers to see the change is occurring. And here's some data. Because everybody is now focused on collecting this information, this is active management of 3rd stage, all right? Something that's needed to prevent postpartum hemorrhage. So at the beginning of this implementation, about 60% of clients were getting a uterotonic at the end of birth, which is pretty good, but it's not what we want. We want nearly 100%. At that time, 3.2% of people were having postpartum hemorrhage in that environment. So they implemented these standards, and very soon, 90% or more than 90% of people were getting the uterotonic. And they could show that postpartum hemorrhage rates had come down by looking at their own internal data. This is, again, very empowering. It's also very empowering to change the minds of those resistant groups. When a doctor is not called in the middle of the night for postpartum hemorrhage, I think he's going to change his mind about encouraging his nurses to be able to give the uterotonic. Right? There are many countries where physicians don't allow midwives to provide certain life-saving drugs. But I think this kind of information can be very powerful. Here's another intervention which I think is going to be huge. Lots of people are struggling with making sure that women who are in preterm labor get their steroid, antenatal corticosteroid, which reduces the level of respiratory distress syndrome once the child is born. So in these particular institutions, only 25% of women in preterm labor were getting their corticosteroid in a timely manner. So they made a decision. They looked at the environment. They said, oh, it shouldn't only be the physicians who should give this. The midwives are right there. They empowered the midwives to give it, and over a period of time, they started reaching their standards, and the proportion of babies, mothers who are in preterm labor, who are getting this steroid had increased up to 60%. Not there yet completely, but moving in the right direction. So I think for me, converting the knowledge that you have, which is everybody should get the dexamethasone, into practice requires this governance mechanism and this measurement mechanism. All right, my last thought on this, and Sandeep, kick me in my shin if I'm going over my time.
Okay, you're okay.
So one of the big challenges in our environment is not only acquiring the skills, but maintaining the skills. Imagine a frontline health worker who doesn't often see a postpartum hemorrhage, but when postpartum hemorrhage occurs, she's got to be ready to do it. If you haven't practiced the skill for a while, then that skill disappears, or your fineness of your ability disappears. We've joined forces with the American Academy of Pediatrics, who are running a fabulous Helping Babies Breathe program. And we created a parallel program which is called Helping Mothers Survive Postpartum Hemorrhage in this case, using very simple simulation models, in this case Mama Natalie, very, very narrowed down, slimmed down version of training packages which are color coded, and very, very beautiful training, pictorial training materials. The idea is to have very short training courses in which people are trained these techniques, and then they go away with the models and the training materials and continue to practice at home. We've recognized that maintaining skills is necessary for them to continue to practice. And the reason why we can do this is because these models, these training mannequins, are actually inexpensive. Mama Natalie was tested. Mama Natalie is a model that Laerdal makes at about $150. This $150 model was tested against models, simulations that are $10,000 here in the United States at Hopkins. And on all 8 parameters of educational efficiency, this very inexpensive model actually outperformed those very, very expensive models. So I think these models have now become in demand in the United States and Laerdal. So it's a fantastic company, a great partnership with a private sector company is now making these models available for everyone that's sold in the United States. They give one away free in developing nations, so buy one, gift one program. So these training programs have now gone to almost 30 countries. And we are hoping that every health worker not only gets the skill, but maintains their skills on each of these. Let me discuss family planning for a bit. Increasing number of women are now coming to skilled providers for birth care, which gives us a great opportunity to make sure that these women, after they've had good, safe birth with a healthy, bouncy baby, they also get their family planning immediately on the day they've had their baby. So immediate postpartum family planning. Many years ago, we used to insert IUDs immediately after the birth of the baby. As soon as the placenta is out, we can insert the IUD. But our challenge in those days was the IUD would fall out, would get expelled. We discovered a colleague of ours in Peru who actually had very low expulsion rates, less than 1% in almost 1,000 insertions that he had done. Vicente Bataglia is his name. And we went and observed his technique. And it was actually a very neat technique that he was using. Now, to be able to teach that technique, we needed a mannequin. So we decided to create this mannequin. It's called Mama U. In a short period of time, from the time we decided we want to do it, our collaborator prepared the model for us. We went and tested it out under Saving Lives at Birth grant in Pakistan. And now, this is already in 20 countries in postpartum IUD programs. And almost 50,000 women have received an IUD immediately post-placenta with less than 1% expulsion rate, which I think is very good. So these are frontline workers who've been rapidly trained up through a very short training program and are doing some remarkable work. Okay, I'm going to talk about 2 more areas of work. In our past 10 to 15 years, we have focused a huge amount of energy on the moment of birth as opposed to the whole labor period. The moment of birth was important for many, many reasons because many issues occurred at that time. But the whole part of that labor is actually important for another big reason, preventing stillbirths. Now, we all know that there are almost 3 million stillbirths or thereabouts every year, which is a huge number. More than half of these are events that occur during the course of labor. Asphyxia that occurs during the course of labor, either because of prolonged labor or other complications during labor. But we don't manage and monitor labor very well. About 15 years ago, I helped WHO develop the modified WHO partogram, which is sort of a pictorial, paper-based depiction of all of the things that are happening in labor. The well-being of the baby, the well-being of the mother, and the progress of labor. So a midwife is supposed to collect all of this information and make sense of 13 or 15 pieces of information to predict problems in labor and to detect problems in labor. It's very complicated. In fact, my students at Hopkins told me, which idiot developed this? And I had to tell them, I was the idiot, right? So it's difficult to do. It's a complicated chart. So what we are now doing is creating a handheld device, a tablet device, in which the information can be entered. The machine plots the data. It nags you if you have missed a particular observation, all right? So a nag feature. And it sends out certain alarms and alerts that will tell you if problems are about to occur or are already occurring. And really more important, uses SMS feature to send the same information to a supervisor. So a supervisor on their tablet can see exactly what's happening. So imagine if you're sitting in a district hospital with 5 or 6 health centers where birth is occurring. A senior supervisor, senior nurse, can actually see the labors that are occurring out there, can proactively provide advice and or receive requests for help. To me, there's got several functions here. It's a training function, it is a management function, and it's a governance function. All 3 rolled up in one. We are about to go and test this out. All of the software has been developed using WHO standards, and it'll be out testing very soon. So let me finish up. There's a significant amount of unfinished agenda that we need to address. First, we need to absolutely ensure that midwives who are graduating, and any frontline health worker who is graduating, is fully skilled at the time of graduation. That means we need to fix pre-service education. We can't do Band-Aid after things have been finished. In-service education needs to be for new things that are coming. We need to focus on respectful care because women will reject poor care and are rejecting poor care. That's a really important thing we have to focus on. There are certain clinical areas that absolutely have been neglected. For example, vacuum extraction is part and parcel of basic emergency obstetric care to be provided in places where C-sections cannot be done. We don't do that very well. I think we have to do that. Certainly we have to figure out family planning and prevention of HIV as part of the package of things that midwives need to do. I've already spoken about clinical governance. There's really no point in just training. I think training must be matched with an ability, some sort of governance, some sort of accountability that investment in training is paying off. And more important than all of this is to ensure that the rights of the health workers are also respected. We often talk about rights of patients. I think health workers also have rights. Those rights need to be respected. So my last slide, these are some of the things that Chapaigo has learned over the years in our training programs. We know that didactic training has little or no impact. So we need to minimize that kind of training. We know that simulation training is highly effective, and we need to maximize that. We know that practice and feedback, in practice and feedback, dosage is important. In other words, you need to do it repeatedly over a long period of time. I think Susan Niermeyer called this low dose, high frequency training, which I love. Put it in small bits, but more frequently. We need to provide feedback, and today with cell phones and everything, virtual feedback is quite possible. We need to make courses shorter, but more often. We certainly need to help providers practice and learn in the space where they're going to practice. Training them in big city nursing schools and midwifery schools is just not sufficient if we want them to practice in rural areas. So we've got to arrange practicums in that kind of setting. And we need to combine training with clinical governance. Thank you all very much, and lots of the materials that I've shown are available on our website. Thank you.
Thank you. Wow, there was so much there. I do want to just note that I don't think there's irony in the fact that both Geeta and Harshad started by talking about that last mile, that we've done a lot of work around this. We have a last mile that we need to go, and what are some of the tactics and innovative training that I think they've both convinced us could be a way. I also think one of the themes that I kept hearing in Harshad's discussion was about empowerment, and that was really striking to me. It was empowering women to be midwives. It was empowering them by showing them instant M&E of their efforts, and then also empowering doctors if they're not getting calls from nurses. And I mean, that was just a real theme throughout, as well as, of course, the theme around training function, management function, and governance function. Harshad, in one of his last slides, talked a bit about the Helping Babies Breathe curriculum. Wow, I don't know how you say that as often as you must. HBB. That's what you say. Which we're going to hear a bit more about from Dr. George Little. He is a professor of pediatrics, obstetrics, and gynecology at Dartmouth, and a fellow with the American Academy of Pediatrics. Thank you for joining us.
Well, great. Great to be with you this afternoon. Hope you don't mind my taking the jacket off. It's still summer and I'm wearing a little jacket. Anyway, it's great pleasure to be here because I've already learned a lot, and I'm really looking forward to the interaction that's going to occur. How many people have heard of Helping Babies Breathe, or what we call HBB? Okay, so maybe a third of people here. It came into my life 6 or 7 years ago. I'm an academic clinician. I've done a lot of things, but most of it's been based on academic work internationally with the Peace Corps back in the days when I was wet behind the ears, right out of training. And now where I'm focusing as the Academy of Pediatrics mentor for Malawi. Turns out that I started out in Malawi and I'm ending up in Malawi. And by the time I can go on an airplane without taking my jacket off, I'll have bookend Malawi in my career. I see it as an exciting evidence of change and as an exciting change agent. One of the real change agents that are coming along, and you've heard some of our other panelists talk about. This is I'm going to give you basically largely a case presentation of HBB, an evidence-based neonatal resuscitation program for resource-poor areas. We all know that there's geographic maldistribution of neonatal and infant deaths, under 5 deaths, largely in sub-Saharan Africa and in the Southeast Indochina part of the world, but they occur every place. And it's a major problem. And I just have to say that I'm a volunteer with the Academy of Pediatrics. I basically have been spending 75% of my time for the last 5 or 6 years with the Academy of Pediatrics. I see it as one of the wonderful things that this country and certain countries in the world have to offer as professional associations that are change agents in and of themselves. The Academy of Pediatrics was not a change agent as much globally as domestically, but it's increasingly becoming a change agent, and also same with the ACNM, the American College of Nurse Midwifery, and so forth. And that's extremely important. Causes of neonatal death, those of you who are familiar with this have seen a lot of pie diagrams of this. This is a relatively old one, draws us to preterm birth and asphyxia and infections. This can be stated another way, and where the asphyxia comes out of the diagram, but in fact what remains are still 3 main causes of neonatal deaths that are preventable and treatable. And this is extremely important. Preterm birth, which we can focus on some of the panel discussion if you'd like to. Complications during childbirth are 2 of the 3 major portions of the pie, and neonatal infections are the 3rd one. But I really want to remain with asphyxia for a minute. This is a slide which came off of the web. I keep asking, anybody know where this slide came from originally?
Tanzania.
Tanzania.
That's
Okay.
Godfrey Baruku.
Okay, well, that's the first time that I got it down localized that well. I knew it's from Africa, and I knew that's right, you were in Kenya as an obstetrician for a long time, if I remember correctly. So he would know where this came from. Well, then I've really learned something today. Okay, very important slide. What does it show? Well, it shows a baby in the process of dying or who perhaps is dead already. And that's an important concept for all of us, and especially for how I'm going to try to go through HBB quickly. It shows a gentleman back here in distress, and it shows a gentleman back here who probably, just by his demeanor and what you see and so forth, is someone who is a mid-level practitioner in a less well-equipped area of the world. But I want you to keep this image in mind, because this full-term, well-developed, well-nourished from the intrauterine state baby is either dead or is in the process of dying. And the question is, what can you do and how do you do it and how can, well, that was the issue that was before us when I joined the Academy of Pediatrics effort on this. It does also bring out the issue of stillbirths, and we're not going to spend time on stillbirths to a great extent, but I just want to remind you of a couple of things, and that is that stillbirths weren't really the focus of major attention until relatively recently. In fact, I was in Oslo for a WHO meeting on stillbirths the night of the first election of Barack Obama. My wife and I, who's a physician, went to bed. The Norwegians stayed up all night celebrating, but that's how near the true focus on stillbirth has been in our history. And we need to remember that, because there are a lot of aspects of that we're not going to talk about today, but it's where HBB, I think, is making a change, along with a lot of the things that Harshad was speaking about. The annual global deaths you always need some issue of magnitude. The point here is that there are some 7.5, 8 million children under fives. If you read the statistics, that many of us know, it's an under fives parameter that we look at. 3.1 million of those are neonatal in the first month of life, first 4 weeks, however you want to define it. And there's somewhere between 800,000 and 1 million intrapartum asphyxia-related deaths. And then there's this figure of for stillbirths, which I'm not going to deal with now. So far as the Millennium Development Goals go, this is a graph which I'm sure many of you have seen many times. And the point is that MDG4, looking at babies, is not going to be met because this is where it would need to be in 2015. And as we see in the under fives category, there's a significant slope in the right direction, but there'd have to be this downward slope in order to reach the MDG4. But look what happens with the neonatal deaths. And the large problem with the failure to obtain MDG4 is with the fact that neonates haven't been as successfully approached as the approach to under fives, and especially somewhat older children due to oral rehydration, infection, and all the things that many of us know about. So there's a basic strategy for HBB, and I think that my associates here and many of you would agree with this basic strategy in some way, shape, or fashion. But it's the first time that I've been with an effort from start to finish, not finish, but where it is now, which is as a change agent. And I just want to phase this in this way to look at the aspect of the strategy of HBB and how it relates to training and so forth. In the first place, it is an evidence-based medical action plan. Now, the primary concepts of the science of neonatal resuscitation have been known for quite a while. They go back to when I was a house officer 50 years ago, believe it or not. And at that time, there were studies that were being done in monkey colonies where they actually asphyxiated baby monkeys and came up with some basic principles. And the basic principles, the science, the evidence for HBB are really quite sound from my estimation. There's a lot we don't know, but there's a lot that we do know. The first place is that the science of neonatal resuscitation is based upon the principle of asphyxia, low oxygen, not having enough oxygen. All the cascade of events that occur. If they become hypoxic, you become acidotic, you have all sorts of difficulties occur from there. The second thing is that there's something called primary and secondary apnea. And primary and secondary apnea is not breathing. Primary apnea is when a baby will respond to stimulation and start breathing. And secondary apnea is when a baby does not respond to stimulation and you have to do things like positive pressure ventilation to get the respiratory center working again and to get the baby in. These are very important principles, and we need to keep those in mind as I go through what HBB is. The third one is that most, not all babies respond if you get to them in time, within 10 minutes, within 8 minutes, something like that. We can argue about that aspect of it. The recovery is possible, and that's another physiologic process that occurs. That's the science of neonatal resuscitation in a nutshell and why we're talking about HBB. Now, what the Academy of Pediatrics did for years, going back to the 70s, is to put together a committee on neonatal resuscitation, and I was with that and chaired it for a while and all that sort of thing. And every 5 years it puts out a textbook. This is the textbook from the 6th edition, which was one rotation ago, but it was the one that was in place when HBB came into being as a spring-off from NRP, but which HBB is now completely independent of that. And this is the action plan or algorithm for the 5 years ago HBB, NRP. And I went out to South Africa and I taught this. And it was nice to have 3 or 4 people at Witwatersrand, understanding what we were talking about. Most other people didn't know what the heck we were talking about because this is based upon very rigorous science and is developed for every place in the United States and Canada, but basically the United States and Canada, where babies are born. It's based upon that science. But the problem that soon came up by a few trips to South Africa, Romania, other places was we're going about this the wrong way. We're teaching it, training it, and so forth in the wrong fashion. So keep this in mind, and then we're going to look in a minute at the action plan, which you've seen a bit when Hashad put up. And the evidence-based medical action plan is targeted at the most common neonatal interpartum problems: asphyxia. Infection's common, other things are common, but not having enough oxygen and being in the shape of that baby that you saw in Tanzania, from Tanzania, is the most common neonatal, one of the most common, or if not the. It's linked to advanced neonatal care if available. In other words, it's not trying to do all things for all babies at all times. It's linked to trying to get to babies and save as many as you can with the resources that you have, but it needs to be linked to advanced care. And it needs to be designated for use in all places where babies are born, and in most places in the world, as you know and I know, babies are not born in a hospital like the Georgetown University Hospital down the street, or the Dartmouth-Hitchcock Medical Center where I happen to work, or even the community hospitals where 40 babies a year in New Hampshire are born, but people are fully trained in being able to resuscitate babies. It's just, there's a lot of thinking that's gone into being it for all babies are born, and this is what emerged. So this becomes this. And I sat there as we went through that process, or one of the people working on that. And quickly you can come out see it. It's much simpler. It uses a traffic signal kind of organizational status with green and yellow and red. And it's got arrows pointing you which way to go, and there's certain steps and interventions that you're trained to do along the way. This is the HBB action plan. And there's a routine care part of it for all babies that gets you started on the path of what all babies need. And we won't go into that at this time, but it deals with issues of drying, crying, keeping warm, cutting the umbilical cord. Then there's another part of the action plan, or another thing the action plan builds into in a logical fashion, and that is what we name the golden minute. And the golden minute is from those studies in the monkey colonies. It said if you don't get started and get oxygen into a baby within a minute, you have got a real problem. So that's the goal. It's a very tangible goal. Everybody understands what a minute is. And I've got a nice little way of illustrating that by when we teach HBB. And in Tanzania, the first time I did this was have everybody stand up and hold your breath. And I say 10 seconds, 20 seconds, 30 seconds, and the last person standing usually is about 50, 55 seconds, something like that. Some people are swimmers and last longer. But the golden minute becomes a very essential part of HBB. And things have to happen in that period of time. You got to position it, clear the airway, stimulate, recognize breathing, and initiate ventilation. And initiating ventilation is not easy. It's a skill set that has to be done to get positive pressure into the lung, and special equipment's needed, and we're going to talk about that. So the second part of the strategy of HBB is an educational curriculum and a teaching methodology. So the curriculum is based upon the things that I mentioned: evidence-based science, but also resource-limited areas, and doing the most that you can with the resources that are available. And it's targeted at all levels of care providers. And you may ask the question, well, what about TBAs, traditional birth attendants? And we can get into that discussion. I'm sure Shad and others have thoughts about that. We have simply, and that's a very important ethical and practical thing, but we're saying that HBB is based at all levels of providers, including traditional birth attendants who may not have any standardized or recognized, if you will, training. Based upon teacher-learner pairs, or dyads, and we talk about 3 of those at a time under a facilitator, and it's knowledge and skill set, and it gets into the training of trainers, cascade kind of implementation that I see some people nodding, and they know about that. So that's the key part of the curriculum and teaching methodology. And this is a pair teaching, and the important part is the dyads flip-flop back and forth. You get assigned at the beginning. If the two of you were here, then you would one moment be a teacher and the other one the learner, and so forth and so on. I think many of you are familiar with that kind of training. And Shad mentioned Susan Niermeyer. She's got another illustration of how this works out and so forth, and it became the essential part of HVB, and it also became part of the hands-on practice, which is very important because I was in Zambia and learned that in Zambia, for example, a few years ago, a lot of people come in for a series of lectures, then came back 2 weeks later because they couldn't be away from their work situation to do the hands-on practice. Well, that's one way that obviously is one thing that doesn't work very well, and it's not part of HVB. It's not part of the basic principles of it. So the evidence-based action plan, the educational curriculum. Now I want to get into what I think is an equal part of the three-legged stool, if you want to use that analogy, for HVB, and that is the clinical and teaching equipment. And we started out on this and then rapidly became involved in a partnership, if you will, with a company, one of the leading companies in the world related to equipment in emergency situations. And this was mentioned a few minutes ago with Layerdal. And so much of what I'm going to talk about here, but not all of it, is related to development and things that have come out of the Layerdal company. It's a Norwegian company, and their foundation. This is the basic equipment of the equipment for the clinical and educational part of HVB. Flip chart, a simulator, a workbook, and it all comes together into, with the exception of the flip chart, what's in this shoebox. And the price on this is cheap by our standards, not by everybody's, and it's produced in China for the most part. It's warehoused in Johannesburg and a few other places to deal with the distribution problems. But I just want to go through a few things fairly quickly. It's got a complete bag and mask which clinically works and can be used in the unit. You're welcome to come up and use this afterwards if you'd like to. In the midst of this was developed a new aspirator. The aspirator has received its own evaluative and process through PATH. And this has got some attributes that many of the old blue, hard aspirators have been shown to actually cause damage if you start rongering around in a baby's nasal passages and throat and so forth. It's semi-transparent. You can see crud in there. If it's there, you can take the head off. You can clean it and boil it, drop it on the floor. It's a great thing for kids about 1 to 2 years of age to play with in the bathtub. And it's relatively cheap. And what do we call it? The penguin. Okay, so this penguin thing is all over the world now. Where's the penguin? We want 1,000 penguins. Okay, well, there's a penguin. The last thing is neonatally. And this is, believe it or not, a full-fledged simulator with all the modern attention and appropriate attention that's being given to simulators these days. And here's a picture of myself in a class. But look at the posture of this baby. Well, what do you do with a simulator? It comes in this shoebox. When we first were working on it, you can, I'm going to have that for a while longer. This would blow it up. Becomes actually a baby that you can take a bag and mask, and the clinical relationship with this, the pressures and everything, are very accurate to the real thing. They were sitting around in Chicago one day, if I remember correctly, and somebody said, well, what have to fill this with water? And then if you fill it with warm water, body temperature water, then it becomes a stillbirth, or a baby that is in the process of dying. Not all stillbirths are dead yet. They're in the process of dying. And this equipment, which I'm not going to spend more time on, is linked with a learner workbook, which basically gives the whole curriculum. We teach it in usually 2 to 3 days in country, and in this country sometimes for shorter periods of time. And this is from one of those teaching sessions. It's now more than 48 countries. HBB in the 3.5, 4 years since rollout is in over 50 countries now. It's in 10 countries, including Malawi, where I work, by being the national program and deemed the national program. In other areas, it's taught by NGOs and other organizations. Implementation, we should have more discussion about this. HBB is designed to be integrated into the WHO program of essential newborn care. That was true right from the start, but it's not all of essential newborn care. It's only for the resuscitation part of newborn care. And we can talk about that if you'd like to. It's intended to be an evidence-based focus of excellence and a change agent. And I would argue that the evidence is on the table that it is a change agent. And I'd love to have more discussion with this. You heard this referred to by Dr. Shad. The Helping Babies Survive, the new Global Newborn Action Plan, which was developed over a period of time and then authorized or recognized in a meeting in Johannesburg, has this number of issues related to care for the babies, the Global Newborn Action Plan. It's called Helping Babies Survive, which I think is an outgrowth of Helping Babies Breathe, which is a straightforward pathophysiologic process that you can interfere with. So the conceptual framework for this has just been moved along. There's something called Helping Babies Survive that is now in the process of being field tested and implemented across the world. Essential newborn care in the first day, which is more than just the resuscitation that you do in the first minute, in the first few minutes, but what you do on the first day. It has the same action plan, pictorial development, and teaching scheme that I've demonstrated to you. Essential Care of Every Baby has, these are the materials for it, flip chart, action plan, same colors, etc. And there's this Helping Mothers Survive, which JPIGO has been doing the field work on, and so forth. Present and future challenges. Well, I can list all small seminar on that. I'd like to tell you what I think has happened in the immediate present and future challenges. I think immediately, for those of us who jumped on the bandwagon with HBB, and there were some studies done in Tanzania and India, well, actually in India and Kenya originally on the teaching methodology and then on the outcomes. So it is evidence-based. There's papers that have appeared in Pediatrics and a number of other places. But the issue of dissemination, procurement and dissemination, I think were the first challenges, at least that we faced in Malawi. But what is very clear now, after 3 years of working there, and we have mostly a countrywide dissemination, but the problems that are really facing, and what I'm worrying about right now for the next 12 to 18 months, is sustainability. Of course, you have to worry what's going to happen when J&J and USAID and all the faith-based groups and organizations that have made this a countrywide process in Malawi, what are they going to do when we pack up and leave? Well, maybe we're not going to pack up and leave, but that's the whole issue, isn't it? But what we really have found is that the challenge of quality assessment and improvement, accountability, things that you've heard the other speakers speak about, how to do this, whether it has an electronic base or not, and there seems to be ways in that be done. That's the real-time thing right now for HBB, is in those countries where it's been implemented and we have data and it is saving lives, how do we get it out there in a total cohort? I have this phrase that I use called TCA, total cohort accountability. How do we get things done in a total cohort accountable, systematic way so this change agent can become permanent, because I'm worried that that's going to be a real problem. I'll stop there.
Thank you. don't know about you, but we met, is it baby Natalie? And I look forward to someday meeting Mama Natasha. I love that they have names. I think that image that you put up there, the fact that we now know where it came from, was really striking, and I think a way to really end the presentation portion of this. I know that that's an image that's certainly going to stay with me. And perhaps in the discussion we can spend a little bit more time talking about how you specifically honed in on how HBB, I'm not going to try to say the whole thing, I failed at that before, really is targeted at all levels of care, including with traditional birth attendants or other training in perhaps how we can incorporate TBAs. And I think it was really valuable how you talked about the action plan, the curriculum, and then the equipment, and how we see that coming in other models that match this. So I know that those are some things that definitely struck me, but perhaps now we can open up the dialogue, and like I said, please raise your hand if you have a question or a comment, and use the mic and introduce yourself and affiliation. So does anybody want to start us off specifically? Otherwise, I'm more than happy to start with my questions. Okay, we're a little shy, so I'll start. And perhaps, Harshad, maybe this is something, since I know you had a slide that had an image, if you could talk us through a little bit about who Mama Natasha is a little bit. Like, we saw the baby, but if you could talk us through a little bit, that would be great.
Yeah. So Mama Natalie is the mother of Neo Natalie.
Oh, I had them wrong. Sorry, I thought I heard Natasha.
And it's a wearable simulator. I'm sorry I didn't bring it with me, but you basically wear the simulator, and you can simulate a full birth, you can simulate hemorrhage, you can simulate a breech birth if you want. And the way we do it is we've got 3 trainees. One of them will be the mother, one of them will be the provider, and the other one will be the assistant. And they all rotate through this process, very much like George described how they do helping babies breathe. So the idea is that the trainer is allowing the progress of that birth to occur, and can hold the baby back, can have the placenta be retained, can initiate bleeding, and the provider is supposed to respond to it. I think people love the idea. They play the role really well. So the trainer will play all the roles of pain during contractions and everything. It gets to be a fun event. Now in many demonstrations, I've got lots of people. The other day, by the way, I had Christy Turlington put this thing on. So if you want a picture of Christy Turlington, who is this famous model depicting her birth, I think it's very, very exciting, and people start using it as part and parcel of their day-to-day work. So I think Mama Natalie has done really well. Let me just say that we took the opportunity of a very large meeting. So there was a major meeting in Kuala Lumpur, the Women Deliver Conference, and we brought in almost 60 global champions, and they were trained over a one-day period on using the Helping Babies Breathe, Helping Mothers Survive package. And then they have now gone to countries and they are starting their own programs. So we are creating these champions worldwide to try and scale this thing up. I also have great concerns about quality and maintaining that quality, because this is a fairly simple intervention, but it's of no value if the quality deteriorates. So that's a big effort that we have to do.
I'll just make one comment to add to that, is that this is, the way I see it is an apron. So males can wear it as well as females and give birth. The other point is that the birth is of baby Natalie. So you go from one curriculum for hemorrhage of the mom, and it just moves right into the action plan for the baby. And the actual birth is baby Natalie.
The other point, if I can mention this, is that in developing nations is usually one provider for both the baby and the mother, which is why George and I are sitting right next to each other. Both of us have to work really together as one individual to provide care for both the mother and the baby. And there are some challenges when both the baby and the mother have a problem. I think it's very disheartening when there's one provider who's got to take care of this. So our training program gives them guidance on how to deal with those kinds of situations.
A quick follow-on to that is that we presented the issue and had a debate with our obstetrical associates, and the consensus is the first golden minute belongs to the baby.
Absolutely.
And not to the mother, because you can look at the risk things that are going to occur with hemorrhage and so forth and so on, and we could discuss that. But basically, we have agreed that the golden minute is for the baby. If you only have one provider, that golden minute is for the baby. And that's very new, and we could talk more about that, but here we are.
We have a question over here on the side. I don't think it's.
I'm Stephen Eads, and I'm working with Midwives for Haiti. We are operating a school for skilled birth attendants in Haiti. And in fact, there's a Christy Turlington connection there. Her organization, Everyone Counts, actually is supporting our current class and the class that graduated last year. The E-modules would fit perfectly in the curriculum that we have. I think every one of them would be extremely useful. You said that they can be in any language. Are they only in English now, or are they? We would need them in at least French and Haitian Creole.
Geetha, if I could just repeat the question, because I wasn't convinced the mic was on. So
not
for
convinced.
for those that are tuning in, because we do probably have, if not more or an equal number of folks tuning in live right now, we have a representative from Midwives from Haiti, not for Haiti, for Haiti, sorry. And he was asking about the E-modules and what languages they exist in now.
All right, this e-module initiative, it's quite new. The entire development of these 9 modules occurred in 2013. So they were completed, tested, and they're ready now in English. The master files are ready. And as we speak, just this morning, we've given the contract for translation of one module, the danger signs in pregnancy, for translation into French and Spanish. And it's a question of funding. So I'm hoping that by next year, we're going to translate all the modules. So hopefully, by end 2015, we would have all the modules translated into French, because we are also planning to launch a major initiative in the Sahel region with the World Bank, which is going to, which was declared by the executive director of UNFPA and the World Bank director in 6 West African countries. So we need them in French, and this has been put squarely into the project appraisal document of that program. So French, these modules will be ready in French, hopefully by end of next year, all of them, and they'll be then available for distribution everywhere. They're free of charge. Anybody can use them.
Perhaps, Geetha, while you have the mic, I had a quick question, which I alluded to a little bit earlier, and that was about the partnership with Intel. Yesterday, we had a representative who works on corporate relations from the UN Foundation join us for a panel, and she was talking a little bit about resistance at the corporate level to get on board with family planning, but that is one of the modules. And so I was wondering if you could talk about the partnership a little bit, and how you went about it, what came first. Intel is huge. I'm curious about that.
That's a very good question. What came first and where we stand now? The partnership came about once. I don't know how many of you are aware. There's something called the United Nations Secretary General's Every Woman, Every Child strategy. Okay, this was to scale up global efforts and commitments towards maternal and newborn health. That this was launched in 2011, I think, or 2010. And many countries came forward and made commitments. And, as that started catching fire, many private sector companies also came and made commitments, including Intel being one of them, GE Electric, Merck, you name it. There's a very, very large list of national governments and private sector who have made commitments to the SG strategy. And at the same time, there was also a big push for innovation that has started within the UN system. And we talk about the Millennium Development Goals, but one of the MDGs is also about partnerships. And somehow, personally, I feel that it's been a misfit because partnership is an essential strategy to achieve any of the other goals, unless you're partnered, because there's so much to be done out there. I mean, even for these e-modules, we have joined hands with JPIGO, all the companies out there. You need to join hands with like-minded organizations, individuals, governments, you name it, all the organizations. So, so Intel, when they made a pledge for reaching 1 million health workers, and UNFPA is, of course, behind, this whole drive towards the SG's strategy, and we were trying to pull in partners. At that time, we got together because there was an innovation working group that was also formed at the United Nations level. And that's how we got to meet, and that's how it got forged in the initial phase. And then we started thinking what to do. Intel actually approached us because I didn't talk about it, but UNFPA has a major global midwifery program, which is now in 40-plus countries. And, it's in collaboration with a large number of partners, including the International Confederation of Midwives. And, since they were talking about innovation for health workers, they were also looking at vehicles for deploying innovative approaches for operationalizing, these strategies. So that's when we started brainstorming and thinking. And when it came to developing these modules, that's when we thought about JPIGO, because they really have expertise in developing this training content, state-of-the-art training content. And we approached JPIGO, and then looking at the materials as to what will be used as the base materials, we approached WHO, because they have this whole impact series for maternal and newborn health. And basically that entire impact series, which is for health workers, has come to life through these e-modules. I don't know whether Harshad agrees, but he's seen some of these modules. But they're like walking, talking modules. I haven't done a demo of these modules, but some of the pictures that you saw, so it's really a case, they're case study driven. So a woman comes to a healthcare facility, and she's having these signs and symptoms. So how do you react? So what are the key issues that need to be flagged, and how do you respond? I mean, I was we've been working with JPIGO now. This low dose, high frequency approach that JPIGO talks about is really something to think about, because it's, what Harshad was saying, again, at the time, unless it becomes a reflex action in an emergency, how do you deal with an emergency unless it becomes a reflex action? And have we trained our health workers to reach that level of expertise where they are responding like this? You're talking about 1 minute, life-saving happens in that golden 1 minute. So really building, but it's a huge challenge ahead to operationalize these on the ground. It's still a huge challenge.
This is a little bit of my dream. I get to fire away. Oh, okay. Can we just wait for a mic? Hopefully one that's on.
I'm not going to, it does work. I won't hog the microphone if somebody else will raise their hand, but this is about HBB, and it's something that we struggle with a little bit in knowing whether or not to actually train traditional birth attendants, because where we're working, we're training mainly skilled birth attendants, but we've found that getting outreach and involving the TBAs is important, and basically getting them to bring their patients to the hospital or to bring them to our mobile clinic. And we've wondered whether we should have HBB training for them. I have a bias devoid of any data, but I just wonder, is there some place where that is being used with TBAs and it looks like it's successful?
And if I could just build on that question, and perhaps for the whole panel then, I know we were talking about innovative training of skilled birth attendants, but I was curious if you could all perhaps comment on traditional birth attendants across the board in your work. George, perhaps you can start us off then.
So it's like most questions, the medical part of it is complex but easy. The political value laid in another part of it is much more difficult. HBB, when it started, was we think, the methodology has aspects we use, but not quite organized in this way. And we made a decision not to say don't teach TBAs. We just didn't make a position on that. We said, however, very clearly that it is the type of program that could be used by TBAs, and in fact, it has been used for TBA training. And I'm well aware of a lot of anecdotal information about, and I've done training, which in Africa where TBAs were there. And you sometimes have to modify it in some ways, but it's what you're really trying to do is bring them into the system in some structured, safe ways. However, it is a hot topic, and when you're short of resources and you're trying to make penetration in a population base and ministries of health and so forth, that has not been a primary priority while we got to where we are with HBB. My feeling is, as a physician, as a person who has trained TBAs and so forth, that it's extremely valuable in that community, but only if done in a way that that community has a role to play within the overall system, because what you're really doing is acknowledging the system. So I hope that's as straightforward as I can be about my perspective of the medical and educational part of it. But I think when you do teach it, if you decide to, unnamed country H, Haiti, if you decide, then in some way it needs to be incorporated into the system. It's got to be part of the system in some way from the start. We could talk about that.
So let me contribute to this conversation. I am a full believer in task shifting or task sharing. But it has to be, we have to be responsible in what tasks we share and shift. So from my perspective, traditional providers or community health providers have a really important role to play in providing evidence-based care in the community. Let me give you some examples of work that we have done. Providing a medication called misoprostol for prevention of postpartum hemorrhage at home birth. We've done studies of this in many countries. It's now in 30 countries. It's taken a long while, almost 15 years, for WHO to grudgingly provide its support for this, but it has saved lots of lives. What we have done is we have taken community health workers, we have educated them, we have sent them out into communities, go house to house, educate the woman, distribute the medication, tell them that the medication is to be taken immediately after birth, and go and check on that. That's it. So it's an education and a distribution role. We do that for calcium supplementation because that will prevent preeclampsia. We do that for iron and folic acid. We can do that for antimalarials. We can do that for bed nets. In my opinion, the value of community health workers and traditional birth attendants is their reach with very specific evidence-based interventions. These kinds of interventions that involve education, talking, because community health workers are, by their nature, learn and understand how to talk to communities. That's what they do. They know how to talk much better to communities than we do. They are engaged. They will talk about cows and the farm and everything else before they get to the thing, which we don't necessarily have the time for. So they can do that well. And then they can provide the information, and then they can provide the medications that are distributed that are, frankly, life-saving and don't require much decision making. So to me, those kinds are appropriate roles for community workers. In terms of actually providing skilled care for birth and other things, I think the jury is out there. We have trained ambulance, they're not really ambulance workers, we have trained our drivers who drive our vehicles in Tanzania and other places to do everything on HBB as well as HMS. They learn it very well, but their opportunity to help is limited. And I think even traditional birth attendants, if you think about this, the big studies on traditional birth attendants are showing that traditional birth attendants may attend a few births in a year. So if you are going to take the energy to train them and then supervise their quality over a period of time, then the impact of what they can do is fairly limited. I think the investment is better spent on creating more skilled providers. But that does not mean that there is a clear role for the traditional systems. I think that redefining that role to include education, distribution, social supports that we don't provide very well is actually the appropriate way to go.
Did you want to add to that at all?
I think Harsha, that's done. Both my colleagues have done a tremendous job of explaining. There was this movement for some time where WHO was really pushing for facility-based births, and where this whole dialogue around traditional birth attendants, it became like a no. It's not the way to go. They don't have the competencies, and then there are studies which say that they don't make a dent on saving lives, really. So again, like my colleagues have said, the jury is out there. But really, I too believe that it's a question about role. If traditional birth attendants have a role in a community, they've been practicing there. If they're in many cases they're respected, and in some cases that is the only access people have to health care. Now, what do we do? Again, this whole issue, which has been gathering steam in the past few years about task shifting and task sharing, is really worth a thought. And countries and governments and and partners, everybody is realizing that you need to give them, if you believe that they're really not the best people or resources to do a safe delivery, you need to assign them certain other roles, like again now the distribution of misoprostol, calcium, condoms, family planning, some kind of antenatal care, or referral to a proper well-trained midwife. So you need to assign them some kind of role. In fact, next year we are hoping to also launch a global midwifery campaign together with FGM prevention and treatment. And we are finding that, that this is also to do with, again, traditional birth attendants, and including midwives who can both prevent and at times can be perpetrators of practices like FGM. So it's a question, I agree, but, with George and Harsha, it's a question of role, it's a question of access. It needs to be looked at sympathetically, the whole argument of what resources are out there. We should not discard that they cannot be trained. They can be retrained, but it's a question of livelihoods. You have to provide them some kind of alternative livelihood. So the issue has to be addressed holistically, and I think I'm happy to see that the trend is moving towards that end, and there's more talk of task shifting and task sharing now.
I don't know if anybody noticed, but Geetha did look at me for half a second when she talked about midwifery and genital cutting. And one of the reasons is we were talking prior to this event what we're going to focus the next couple dialogues on. So stay tuned for that if that particularly struck you. I had a quick question for anybody who might want to answer this. I think Harsha probably has some ideas, but what's next? What's in the pike that we haven't heard about yet? And that we can look forward to potentially having another session on. Is there anything we don't know about? Any technologies we haven't thought about yet?
Yeah. Let me take a shot at this. I think there's a lot of excitement about technologies, and I think rightfully so. I think today we have got a point where some dramatically new advances can occur. I am astounded by how dramatic the expansion of mobile phones has been. But I think health workers have not sufficiently looked at other sectors that are using these kinds of technologies. I had the opportunity to go and look at agricultural workers, how agricultural workers are using cell phones to monitor their crops, to get the right kind of fertilizers into their from central places. It's amazing what they're doing. I believe that health workers have been a little bit shy about using these platforms, and I think we need to examine these platforms, and we need to become more aggressive in using those platforms. I find that that many of the things that we need to do, for example, just the follow-up, the triage of follow-up. We have got a male circumcision program, a global male circumcision program for preventing of HIV in many countries. We do almost all our follow-up by making a phone call. We can ask 10 questions, and we can then encourage people to come back if there are issues. And we're getting a fairly good coverage, much bigger coverage than asking people to come back 40, 50, 60 miles to the clinic. To me, there are some advantages of these technologies that we can, but One of the other things is, of course, not many of us have spent, let me just rephrase it. I think we haven't spent sufficient enough time in evaluating the value of these technologies. I think so there is promise, but there isn't the fullest of evidence yet. I think we need to work towards getting that evidence and then using these technologies. One last comment on this. I think apart from technologies, we need innovation in systems and in programs. So when I spoke about clinical governance, it is not a technology innovation. It is, in fact, figuring out how people do what they know to do and what they've learned to do, and how to reward them conceptually, physically, other ways, by seeing that they're getting the results, making it a little bit more visible. To me, those kinds of innovations are also needed.
Anybody else want to add to that?
I'll just throw in a quick one because I think it's a very complex question. I think the next thing that's going to hopefully have, while we continue with HBB and the maternal hemorrhage aspect of it, which are the keys into, they open the doors into these other issues, is going to be the issue of small babies and premature babies. That's a huge cause of maternal, at least morbidity, or it's a result of maternal morbidity and mortality in many situations, and a lot of babies die that way. There's an effort underway that has all the characteristics of what something hasn't been mentioned here, which is the GDA, the administrative format. And I think you'll see midwives and obstetricians and pediatricians really focusing on the small and premature baby. It's in the works. It's the strategy is being laid out as we speak.
That was also something we talked about a few minutes before this dialogue, too, about upcoming dialogues. I think we have a question there.
Yes, I'm Ali Abdelmajid. I'm a maternal health advisor at Jobaigo. First, actually, for Harshad, you mentioned about the clinical governance, and actually it's like a kind of a new terminology, and maybe it will be good to shed a bit of light on it, how that will work out. Is that a kind of the approach, if you are joining the training as an approach, so together they will doing better impact as you mentioned. So that could be a possibility to add. I have another quick question also for Gita. That's what the e-learning seems, of course, a very, very important tool now, and with innovation and to reach really to the unreachable. But quickly, when I was just recently in Yemen in a field visit, and we worked with one of the working in service training for the midwifery schools there. So the idea is really to try to do something through the tablet or the iPhone. So they were there very hesitant when they just hearing we are talking about working with the tablets and putting some of our tools there, and they need to work with it. So I think it needs a kind of parallel with that, to have a kind of the champions in each place that they can really doing the advocacy part, as was mentioned earlier. That's we didn't really test it enough to be used in the full capacity, and it could be really a very good support and help in the health arena as well. Thank you.
Yeah, thank you very much. I think that's, for me, maybe I can't give you the exact definition of clinical governance, but the concept here is to really largely figure out how do providers continue to practice the skills that they've been taught. How do you transfer learning from sort of the learning environment to the work environment? And how do you ensure that that learning continues to be maintained over a period of time? What are the strategies? You can call them performance improvement strategies, or I call them clinical governance in this particular case. But for me, one of the most important aspects of this is giving people some sort of gratification for the effort that they are making. So if you're asking people to practice a certain intervention, they do need to see that this is bearing results for their institution and for themselves. So I think measuring that you've achieved certain standards and your postpartum hemorrhage rates are sort of getting down in your environment, that you're not using as much blood and your linen is not as much soaked and stuff like that, those are important reinforcers of those practice. So we have to use whatever reinforcement there is, because it is working alone and in remote areas is sometimes very demotivating. When visitors come from outside, most times they are yelling at you. They are not understanding your challenges. I worked myself in district hospitals. The visitor that I liked the best was first the person who tried to understand what my challenges were and then help me meet those challenges. To me, this is critical. So how do we help this person to continue to maintain those standards and get that gratification? Because it can be very frustrating. People die. I went to a place in northern Nigeria, Bauchi, where there was a maternal death every day for the week that I went in. It hurts every provider hard. You can be paralyzed by that, and to the point that you feel that your own abilities are just not sufficient in that kind of environment. How do you then motivate that person so that they start believing in their skills? That nurse that we showed in that picture, if you think about this, for her to have stood up in front of a man in that place, for her to have insisted on going into that hut to help that woman, if something had gone wrong to her, she would surely have been killed in Afghanistan. That's what would have happened to the world. But she felt so empowered. To me, we need to find better means to constantly empower our health workers with capabilities, with confidence, and with certain kinds of rewards.
Talking about empowerment again. Did you want to add anything in terms of the advocacy and champions?
Yeah, but what Harshad was saying, I was also wondering, when you speak about governance, would it, apart from maintaining competencies and empowering them, is it also an issue of authorization, of what skills they are authorized to practice and whether they are prevented from practicing skills, which typically is, take the example of a midwife, say manual removal of placenta or, certain other functions where they are prevented in countries. I mean, that in a typical sense might fall under governance capacity or a governance category, or in your view, that does not fall under governance category? Sorry, that was a counter question to my colleague here.
I think certainly there are all aspects of governance. I think clearly if we set standards in a nation and we decide that we want to empower or we want to train somebody to do certain functions, then we got to support those functions. I think in most countries today, you do have policies that are actually progressive in terms of task shifting. We are a lot further along than we were 10, 15 years ago. I think the challenge is that at individual level, at institution level, there are still hierarchies of medical care that people are afraid of and are not sufficiently responding to. So, I believe in task shifting, and every time I go and train folks to do a task that was supposed to be done by other people, people often ask me, "Oh, you're taking away our bread and butter." But the reality is you're getting a job done in an environment where the job needs to be done. So if I train anesthesia providers, the anesthesiologists can be up in arms that that's not something we want those folks to do. But they don't have a solution for providing that anesthesia in that environment. I think we've got to find solutions, show that they are effective and safe, and then make them scale up. So I think we have a lot of tasks ahead of us in terms of training people to competency and then getting stakeholders to authorize those services. I think from my perspective, if somebody is trained to do a task, they have been certified to be competent and proficient, then there is absolutely no reason why they should not practice that skill. That seems obvious to me, because even in the most challenging environments, at the end of the day, nurses and doctors are trained to save life. If they are the only one who is there, they've still got to do certain things. They cannot just sit and watch. They have to do certain things. So And this happens everywhere. It's not as if they don't do it. So there is no, I don't know of any country where somebody will be penalized for trying to save lives. Yes, there'll be a lot of debate about it.
I think Geetha did something that I was remiss in doing, and just if any of you have a question for each other, and then I know there was one question I thought I saw a hand go up on the side here.
Should I respond to that?
Yeah, of
gentleman?
course,
Sorry, the question about advocacy, about e-learning, you're absolutely right. We have to do it. It's, on not just advocacy, it's a question of setting up the whole system. The IT infrastructure, the back end, the tracking, the systems administrator. So it's not, we could go the simpler route of getting these courses on CD-ROMs and distributing them, and people can do them. But then how do you track it? How do you really track and monitor the progress in doing the courses? So that's one. The other point that I wanted to make was that currently these modules that I've shown you will not work on tablets and iPhones. They are not for Android devices, but it can easily be done. It can be converted. It's again in the next phase. Hopefully, as we get funding, we will convert them for Android devices also.
Questions for each other, or we can grab the one on
I
this
wanted to
side?
make a point about partnerships and ask others to comment on partnerships. For me, partnerships are critical. So our partnership in India with our virtual classroom project, which is, by the way, almost about 40 modules, they're all available, is with Cisco and with DFID, the British Assistance Agency. It has been unique from many perspectives. Because bringing together an IT partner who can provide some sort of back-end platform support, which is very complex, and bringing together schools, nursing schools, and the nursing council is not an easy task. But once they come together, then I think it works. I think one of the things that we have to understand about partnerships is that if we don't develop these kinds of partnerships, we cannot make the kind of progress that we can make. Our relationship with Lerdal has been phenomenal. And, I think in the olden days, and probably even today, many of us in public health grew up demonizing commercial entities in many different ways, because all we thought about commercial entities was they're out for large profits and whatnot. I think that situation has changed completely. I think there are very many commercial entities who have an incredibly huge social mission, who really want to make things better, and who are working very closely with public health groups in figuring out how we can get frugally designed, lower cost, and effective solutions that will help larger number of communities. I think partnership is key.
I just noticed somebody twice raised your hand and didn't get a chance to ask.
Can we just get you let's get these two questions at the same time, and then perhaps you all can answer them and provide any
Okay,
concluding
great, yeah,
remarks.
yeah.
And thank you for noticing that. I can't see
You
everybody.
can't say everybody, you're right.
Hi, is this on? My name is Priya Kwam. I'm a graduate of the Gender Institute at the London School of Economics. My question is for Dr. Little. You mentioned that there's part of the training module has to do with recovery and keeping the baby, the neonate, alive after the golden minute and after the initial efforts. And I was wondering if you could elaborate on that. And then I have a second question, which is about the respectful care, which is a term that you use, Dr. Sanghvi. And I was wondering if that differs in any ways from the basic quality of care framework, if it's more nuanced in any way.
And if we could just grab that. And were there any more that perhaps I'm missing? Oh, okay.
My name is Melissa. I'm a graduate of Johns Hopkins Bloomberg School of Public Health, and I'm now working at the State Department. Thank you to all the panelists. I think this question is probably best directed to Dr. Sanghvi, but I would love comments from all the panelists. One of the interesting points that you made was that you recognize the importance of bringing people of unlike minds together. And I'm wondering, I believe the collaboration among diverse stakeholders can really lend itself to excellence. And I'm wondering if you can elaborate a little bit on that approach in this context.
All right, so perhaps we can just go down the line. I don't know if Georgia Geetha wants to start us off, but hear a little bit more about Unlike Minds working together, about recovery and respectful care.
Well, the specific question about the action plan for HBB, and it's part of the training, but it's a very vital one. If you look at that, envision green to the left, yellow, and then in the far lower right-hand corner is called the red zone by those of us who are even those of us who are not particularly enamored with the football society. It really means something. And that's an important part of the training. You've hit upon a very important, at times frustrating, vital concept that when you do training that is selective for perhaps high impact things like maternal hemorrhage or babies who are asphyxiated, you're not able in many in the environments where you are training people to give them a specific way to get into an answer, because ambulance systems don't work. Telephones do, but ambulance systems don't work. It's 100 miles or 1,000 miles or some miles to where there's a blood bank and that sort of thing. It doesn't mean it won't be there 20 years from now or 10 years from now, but that's where I really come back to this issue that you have to be systems-based, and you have to have teach respect for the system that the work we're doing is where it happens to be. In other words, I didn't say that quite right, but you have to teach respect for the stage of development of the system, and point out that there will be babies who die because you can't get them to the next step, but 10 years from now, here's why and how we'll get them into the process. That's part of the empowerment and the support of interpersonal dynamic that has to take place, it should take place in all of our work, but is, I think, a special challenge in what we're dealing with today. Does that get at your, that?
I think I was referring to more specifically what recovery entails that first day of life, what kinds of actions can be taken.
Come up and see me afterwards. I'll point you to the specific parts of the evidence-based part of the curriculum. I'd have to give a little, I don't want to give a lecture on it. We'll talk about it.
I think respectful care is part and parcel of an overall quality of care framework. But I think I particularly highlighted respectful care because recent studies show how serious and how prevalent disrespectful care is in labor wards, in maternities around the world. There are all kinds of, very overt and very covert types of respectful care, and I think it's heartbreaking. Here, I think as public health professionals, we are encouraging women to come into our institutions for care. If we do not provide them care that is evidence-based, that's technically sound, but that is also respectful, then we cannot expect them to come to care. I think it is a very critical area of work, and a lot of people are getting engaged in this. There's a lot of interesting work that's going on in this area, and I would encourage all of you to read some of the unique work that USAID, for example, is doing in this particular area. The other issue I think you raised was about unlike minds. By the way, this is something that a colleague of mine, I don't take credit for that word, but Joy Lawn, who is an amazing pediatrician, thought about this some while ago and says that's what we need to do. And I really believe that. I think when I speak about unlike minds, I think that we tend to become isolated. Previously, we were isolated as obstetricians and as midwives and as pediatricians. We need to come together, but we also need to come together in a much, much bigger manner. So, for example, agriculture, right? So nutritional issues are major issues of poor health among women. We need to work a little bit closer with our folks in the nutrition world and figure out if there are synergies that can be achieved. I have had the opportunity now to work with biomedical engineers. It's been fascinating for me because a lot of young biomedical engineers are really, really eager to design and develop the kind of frugally engineered technologies that are relevant for the developing world environment that we live in. It's fascinating what these very, very bright young people can do for our things. And I think engaging with them in a systematic manner is going to reap benefits. I think people who work in the finance world, we have to find creative ways in which to finance our endeavors and our healthcare and whatnot. And I think if we don't work very closely with them, then we are not going to be able to sustain the gains that we have got. So I think bringing people from different sectors together to have a sort of conversation around a particular problem. Let me give you one final example. I had the opportunity to meet with a systems engineer. Systems engineers are, at Hopkins, there's a whole group of system engineers who helped land the lunar module on Mars or wherever they land these modules there, right? They have to think a lot of things. And I asked a group of systems engineers to tell me how they would deal with the problem of postpartum hemorrhage. Well, they came across a number of things, but one of the first things was there was a whole group says, let's talk about how we're going to build better roads. Right? Because if you don't have good roads and good transportation, you're not going to be able to deal with postpartum hemorrhage. Now, how many of health workers actually think about those kinds of things? I think they started having an onion which had so many different layers of different things they could do. So their solutions started becoming much broader and potentially more useful, I think. So I think that's what we need. We need to open our minds to different domains and figure out if those solutions are important for us.
Great thoughts. First, about respectful care, I think I totally agree with my colleagues here. But apart from respectful care being part of the whole quality of care model, I think it's also a basic human rights issue. I think each woman is entitled to respectful care in maternity. And, it's such an integral part, but it's often forgotten, which has led to a very dangerous situation in the sense that women no longer trust health facilities. They don't trust health providers simply because it's better to die at home than travel and spend all the little money that you have and come to reach a facility and then die there. So that has been an outcome of the lack of respectful care or disrespectful care, as Harshad put it. That was point number one. Secondly, again coming to this partnerships and unlike minds, and I'm again struck by one concept that came out as we were talking and having this dialogue. It's about comprehensive innovation. Innovation by itself, none of these things by itself would work unless the systems are in place, unless there's program management, unless there's evaluation. All those little pieces need to be put together. Otherwise, a thing does not become reality. It stays in a workshop. That the example I like to give is people come, talk, and go away, and it's forgotten. So for it to become reality, you need to get the stakeholders together. You need to get the resources together. You need to operationalize a concept. Otherwise, it will remain a beautiful idea. It won't get out there. And for that, really, let's all engage together. And that's my last word.
There were a final thought before I ask you to join me in thanking the speakers. Harshad referenced transportation. Also, we've heard a couple conversations about respectful care, and I do just want to point out that our events are often webcasted live. In either case, the video is archived and online. So if either of those two topics, for example, interest you, you'll see that we've had sessions in the past on them. So I'd encourage you to check them out. So we have our website that you can follow us on, our blog, as well as Facebook and Twitter. So let's continue this dialogue through those means, and please join me in thanking our wonderful panelists.